Thank you, Carol, for the kind introductions. In the next 15 minutes, I will talk about how I overcome acquired EGFR TKI resistance. It will be a challenge to complete the topic in 15 minutes time. And it was a miracle that we were not able to achieve in the past. In a patient dying this late with bilateral lung carcinomatosis, upon the detection of a sensitizing mutation on the plasma and exposure to the appropriate tyrosine kinase inhibitor, in less than 3 weeks' time, you see the resolution of the lung metastasis and returning from a dying patient to one that's well, symptom-free, and prolong his survival. That has to thanks to the improved understanding of lung cancer genomics. In the past, we know nothing about lung adenocarcinoma, just that it behaves differently with benefit more from certain kind of chemotherapy. Nowadays, we know that for each of them, there's a possibility of a driving mutations that are driven the tumor growth in an uncontrolled manner. After the topic just before, now we talk about the EGFR. Although the initial good response can be demonstrated in majority of patients, resistance will invariably occur. These are the phase 3 studies of EGFR TKI as first-line treatments in patients with EGFR mutated non-small cell lung carcinoma. You see the progression-free survival is kind of fluctuating between the figures of around the figures of 11 months, probably because of a better selection for the patients. For example, in IPAS, certain type of mutation are being included, like exon 20. Mutation, which are known to be resistant to EGFR TKI. I try to divide the way to overcome resistance in 4 steps. First of all, you have to understand what the potential resistance mechanisms are. These are those acquired resistance mechanisms. Majority of the case are T790 mutations, and other could be HER2, MEK, PIK3CA, BRAF, or even morphological changes like epithelial mesenchymal transition or small cell lung cancer transformations. You could also group those acquired drug resistance mechanism into that way, either target alterations of T790 or amplifications of EGFR, bypass parallel pathways to the HER2-free, MET amplifications, IGF-1R, or downstream pathway with BRAF, MEK1, or PIK3CA, PTEN-NOS, or even histological transformations, small cell and epithelial to mesenchymal transitions. That way of understanding is of paramount importance in choosing the subsequent therapy when there's acquired resistance. For example, in the combination of effectively cetuximab, that trial phase 1B with 200 patients, the dose at expansion phase effectively 40 milligram daily. Cetuximab 500 milligram every 2 weeks. It demonstrated a decent acceptable response rate of 30%, 32 in T790M mutated patient, and 25 in those T790M negative. However, there's a caveat of these studies. Patients are not restricted to a patient with immediate TKI failure. This is understandable. Phase 1B trial, you should expose all possible therapy before enrollment, but that would make a proportion of the response just attributed to the effect, the phenomenon that we observe as retreatment effect. So you use first line EGFR TKI, bridging with chemotherapy, and then followed by EGFR TKI. Even you use the same agent, around 10 to 50% of this patient will respond again because of the presence of some sensitive clone to that EGFR TKI. And if you believe in the so-called pan-HER inhibition of effectively cetuximab, that combination is helpful in target alterations in bypass pathway for HER2-free, or to a lesser extent some of the downstream pathways. But it's not possible to be respond to MET amplifications, IGF-1R mutations, or histological transformations. You have to also define what is resistance. That's the usual way we define EGFR TKI resistance, so-called the Jackman's criteria. To define resistance, the patient has to be on TKI alone, and there's long benefit with PR or CR, and there's proven evidence of stable disease of more than 6 months. At the time of progression, you have to demonstrate progressive disease by RECIST or WHO criteria. And the interruption, no interruption is allowed more than 30 days. That's very important because we observe a phenomenon of tumor rebound upon cessation of TKI. You see, in 3 weeks' time, there's a rapid regrowth of the tumor mass. And upon resuming the same TKI, those sensitive cone will regress to the same agent again. The aspiration studies is always a reminder to tell us that sometimes we can continue the EGFR TKI beyond resistance for those slow progressive disease. A median gain of 3.7 months if you try to continue the agent beyond progressions. But the child doesn't just appropriate the overall survival issues, but it's always a kind reminder that for slow-going asymptomatic patient, you can continue the EGFR TKI. And we have to know that there are 3 types of progressive disease: systemic progression with progression everywhere, or oligoprogressive disease with limited number of progressions that are assumed to harbor those resistance cone. By ablate it with resect it with surgery or ablate it with radiations, theoretically you can continue the EGFR TKI, and those resistant cone are assumed to be eradicated. And there's also what we call CNS progressive disease. It's largely due to inadequate drug penetration of the drugs. And there are 2 approaches to tackle that problem. Either you give focal irradiation to limit the number of brain metastases, or whole brain irradiation when there's so many brain metastases, and continue the original EGFR TKI. Or you switch to another kind of EGFR TKI that's more CNS penetrating. I expect in the future you don't see that type of CNS only progression, because there are more and more target therapy are much more CNS penetrating. For osimertinib, it's 30% available in the brain, while for the erlotinib, it just maybe 3 to 4%. For ALK-positive disease, crizotinib is just less than 0.5%. But now we have alectinib and also lorlatinib with 80% availability in the brain. So in the future, you may see it as a kind of subcategories or subtype of oligoprogressive disease instead of just the mechanism of inadequate CNS penetrations. We have to detect the resistance before we can overcome the resistance. But mind you that there's no approved therapy other than osimertinib for those acquired mechanisms of drug resistance. Only in small cell lung cancer transformations that give you a hint to give etoposide platinum chemotherapy, but others always palliative chemotherapy doublet using a pemetrexed carbopectin in majority of the cases. And from the all 3 studies, randomizing osimertinib versus pemetrexed platinums after EGFR TKI resistant to first and second generation EGFR TKI. It demonstrated a gain in the progression-free survival of 1 6 month, hazard ratio 0.3. And we looked at there's also many ways to detect EGFR T790M mutation with variability in the analytical sensitivity and also different areas of applications. And we now have liquid biopsies, and it was demonstrated in the OR1 and OR2 extents combined genotyping analysis that either you detect the mutations by tissue or plasma, you got an equivalent progression-free survival of around 10 months. Only in the T790M plasma negative patients, there are 30% chance of false negative, and you are mandated to do a tissue biopsy. And once it's positive, you can use osimertinib, and this group of patients will benefit from it. Often, there's some disformed graph. Which one is better, tissue or plasma? In fact, there's no gold standard, and with pros and cons of each. For the tissue biopsies, you can only assess 1 sample at a time, but for the plasma, theoretically, you can sample all tumors, and most likely from progressing tumors. By biopsy more than 1 site, you can potentially capture heterogeneities, but not all patients are able to profile an adequate biopsy at the time of progressions. Being its non-invasiveness, plasma testing can do it on all patients, and you can do it repeatedly to monitor for the drug response and resistance. And tissue biopsy can capture all resistant mechanisms, but plasma, you would always miss morphological transformations, small cell lung carcinoma transformation, and epithelial mesenchymal transitions. And you need a quite high sensitivity assay for the plasmids and with cost implications. And some tumors, just no matter how, would not secrete the cell-free DNA into the plasma. And it's been known that the formalin that you use to fix the tumor can cause artificial T790M mutation. Mind you that T790M mutation is a simple cytosine to thymine transitions, and it's very prone to the eliminations by formalin. By ACG here is actually the only encoding sequence for threonine, and for ATG is the one of the encoding sequence of methionine. So by simple C to T transitions by formalin, we can create an artificial T790M mutations. The study using a mutant enriched PCR was reported 0.1% sensitivity on those paired samples. If the sample is FFPE, formalin fixed, you got a 70% chance of T790M mutation de novo. But if you use the Fosun section, there's no detectable T790M mutations. So if any trials that you come across with unexpectedly high incidence of de novo 7 T790M mutation, you have to look into the assay that they use, where they use two sensitive assays for detections. This is a very basic slide, but we just focus on the EGFR part. This is often I show to people about the time for the biopsies. For patients with first or second generation EGFR TKI, after exclusion of oligoprogressive disease, they do the biopsy, either liquid or plasma or tissues. T790M use osimertinib. And upon further progression, you have to look for any presence of C797S mutations or others resistant patterns. And according to the plus or minus trans or cis location of the C797S, you can use either the original first or second generation TKI or combined with osimertinib. DAC cis or translocation of the C797S and T790M mutation has been advocated with strong implication on whether we can use the combination therapy. And but the prevalence of DAC cis or trans is not known until 1 month ago. In the World Conference of Lung Cancers, World Conference on Lung Cancers, the patient with C797S mutation and use NGS to detect for the C797S, it finds that in fact majority of these patients are in cis configurations. So you cannot use first and third generation combination in majority of the patients, just around 10% you can use it. And at last, after knowing the mechanisms, you have to choose the best available next line of therapies. But unfortunately, there's lack of strong evidence so far, and most of the studies are in the very early phase, and there's a strong problem with treatment toxicity because many a time they use a combination therapy. And with combination therapy, there would be anticipated of high financial toxicities. The story would not be complete without mention of intrinsic resistance to first and second generation EGFR TKI. It happens in around less than 20% of the patients. But now we started to have hints on that in the areas like the low 4790 mutations or exon 20 insertions. From the FLORA trial, this first line osimertinib, they demonstrated improved progression-free survival comparing the standard of care first or second generation EGFR TKI with hazard ratio 0.46. So the low 4790M is theoretically be treated better by the use of osimertinib. And that drug's positioning is an EGFR exon 20 inhibitor. And from the early clinical data, it can achieve a response rate of over 70%. So that's a summary. In order to overcome the acquired EGFR TKI resistance, we need a thorough understanding of all oncogenic pathways. Evidence evolves slowly and remains immature, but valuable in patient exhausted or existing treatment options. Tissue and plasma with biopsy are complementary to each other. None is gold standard. Cause, legal issue, especially in public hospital, treatment toxicity, and tumor heterogeneity are always the issues in selecting agents to overcome acquired EGFR TKI resistance. Thank you.